Assalamu alaikum jami'an. I'd like to welcome you all to our third webinar on thyroid webinar series. My name is Khalid Al-Dahmani. I'm adult endocrinologist at Tawam Hospital. I'm also the scientific committee chairperson for the Emirates Diabetes and Endocrine Society. It gives me a great pleasure to moderate this third part of the thyroid webinars. And it's a great pleasure to have 4 experts that will be presenting on different topics related to hypothyroidism. This is the third part of the series, and we have 3 more to go. I'll share with you the details a bit later. We move to the next slide. So just a few items before we start. I'd like to remind you that we are also live streaming the webinar on our EDS YouTube channel. If for some reason that you would like to go back and listen to the presentations again, they'll be available on demand. And I advise you to type your question in the Q&A box. Please mention the speaker's name if you have specific question to that speaker, otherwise I will select. And just if you need any technical support, then you can chat with us on WhatsApp, and the number is provided here. This webinar is accredited for 1.5 semi-hours through the Ministry of Health. Next. So just briefly, the view or the framework of this webinar will be 4 talks. Each talk is about 35 minutes. We'll address different aspects of hypothyroidism. The first talk will be presented by Dr. Salman Razvi, and he is going to discuss management of hypothyroidism, how, what to do. Dr. Razvi is a senior lecturer in endocrinology at Newcastle University and a consultant endocrinologist at Queen Elizabeth Hospital. Is interested in research related to thyroid action on the cardiovascular system. He is well published, ATB reviewed publications and book chapters. He is a member of the editorial board of JCM Thyroid Frontiers in Endocrinology and the Journal of Endocrinological Investigations. And we are looking forward for his talk. We can turn over now to Dr. Razvi to start his presentation. for our team. I think we cannot hear the speaker.
It's once again a great pleasure to be here with all of you in the series of thyroid disease management. And today I'll be talking to you about the management of hypothyroidism, how and what to do over the next 30-35 minutes or so. These are my disclosures. You all know this very well. This is just to remind ourselves that the way we diagnose thyroid disease, thyroid dysfunction, and particularly hypothyroidism is by measuring TSH in the blood. TSH is considered to be the best diagnostic marker of thyroid status inside the body, inside each tissue. And high TSH with low T4 levels is overt hypothyroidism, and high TSH with normal T4 levels is classed as being subclinical hypothyroidism. Hypothyroidism, the prevalence that's stated in literature varies quite a bit, and most data is present for the United States, certain parts of South America, and a lot of European countries, and Australia, China, and India. But as you'll see, there's not a lot of information about this part of the world, the Middle East, that we are interested in today. The causes of hypothyroidism, the most common cause is iodine deficiency. But these days, when iodine deficiency isn't really a major issue as it used to be in the past, these days it's mostly autoimmune disease, that is Hashimoto's thyroiditis. There are a number of other causes, and notably, post-radioactive iodine after thyroid surgery, post-hemithyroidectomy, certain medications, anti-epileptic, radiotherapy of the next, post-thyroiditis, where it may be transient, infiltrative diseases of the thyroid, like infections, lymphomas, sarcoidosis, inflammatory conditions, and so on. Then the secondary causes of hypothyroidism related to pituitary or hypothalamic causes. Again, I've listed them out for you. And some of the very rare conditions where there is peripheral high consumption of thyroid hormones, such as hepatic hemangiomas due to high deiodinase 3 levels, which inactivate thyroid hormones, leading to systemic hypothyroidism. But these are relatively rare, and only certain hepatic hemangiomas have been reported in the literature as causing this. Coming back to this point about the prevalence of hypothyroidism, there are no large community-based studies to determine the population-wide prevalence of hypothyroidism, not in the Middle East and certainly not in the UAE. There's some hospital clinical data, which isn't ideal because it tends to be rather biased, suggests that the prevalence is higher than other populations. And I've certainly seen this being discussed by a lot of colleagues from the Middle East who say, oh, well, hypothyroidism is very common here. But again, it's because we see a lot of it in hospitals. What we don't really know is in the wider community, in the general population, what is the prevalence? A study from Saudi Arabia reported a prevalence of subclinical hypothyroidism of about 10%, which isn't that different from a number of other studies elsewhere in the world. So that makes one wonder whether the reported prevalence may be similar in the Middle East than it is elsewhere. So then it brings us back to the question, why do we measure TSH for thyroid hormone status? Why do we not just use T4 levels or symptoms? And the answer is because of this unique relationship between TSH and free T4, which is log linear. What that means is for a 2-fold change in T4, we get a 100-fold change in TSH. And for those of you who, like me, find mathematics rather difficult area, to comprehend, then I've tried to get it shown here in a schematic fashion. So imagine somebody who's got normal thyroid function with a TSH of 1.5 and a free T4 of about 19 or 20, which is both within the reference ranges. And over time, this person's T4 levels come down from 20 to 10. So that's half of where it had been previously. Now, it's still within the reference range because the reference range goes, say, from 9 to 22. Both 20 and 10 are both within the reference range for free T4. So if you just use the T4, the 20 would have been normal and the 10 would also have been normal. But if you go back to the previous slide, what we know is that for a halving of the free T4, we should see a 100-fold increase in TSH. So what should happen to TSH is that the TSH will go from 1.5 to about 150 or more. So that tells you that for very small changes in T4 levels, circulating T4 levels, the TSH levels tend to have very large changes. Therefore, TSH is deemed to be a very sensitive marker of tissue thyroid hormone status. There are a number of arguments both for and against this, but at this point in time, the people who argue for TSH are in a majority, and the evidence also is kind of in favor of using TSH. But what it could do is that we measure thyroid function in people who report symptoms, and that might lead to a selection bias. And because the symptoms of hypothyroidism, and we'll come to this in a second, are so very unspecific, non-specific and common, even within the general population and even within the euthyroid population, it's very difficult to know what symptoms are related to thyroid disease or hypothyroidism and what might be related to lifestyle, for instance. For example, weight gain is a very common complaint made by a lot of patients and leads to a lot of thyroid function testing being done in this population. Now, it's very difficult to know how much of the weight gain is lifestyle related and how much of it's actually related to thyroid disease. I'll share with you some data that suggest that actually it's the other way around. It's the weight gain that's causing the TSH to change. So how do we come up with the TSH reference range? The thing to remember is that it's usually calculated from a healthy population, and that generally tends to be people who have had family history of thyroid disease taken out, TPO antibody status negative, not on any medications affecting the thyroid function. Generally tends to be younger people, even if it's not all younger people, the vast majority of the contributors to the population that is used to define normal or the reference range tends to be younger, fit, healthy people. And therefore, it's very different to a usual clinic population that tends to be older, on a number of medications, obese, and so on. So we have to keep these certain limitations in mind. And going with this, then we also have to keep in mind what the factors may be that impact on TSH levels. We know that iodine deficiency, severe iodine deficiency, can cause hypothyroidism, but we also know that prolonged iodine deficiency can lead to a nodular formation, and if these nodules start producing excess thyroid hormone, then the TSH may be low. So iodine deficiency, depending on the length of duration and the severity of the deficiency, can cause both high as well as a low TSH. Age, and there's a lot of evidence that suggests that as one gets older, TSH levels tends to be higher. The race tends to have an impact. Afro-Caribbeans tend to have lower TSH levels than, say, Caucasians or even Arabs or Asians. There's a lot of diurnal variation in TSH, where TSH levels tend to be highest first thing in the morning and lower in the afternoon. People who smoke tend to have lower TSH levels, and who have recently given up smoking tend to have higher TSH, as also have higher anti-TPO antibody levels. TPO status is also important. People with positive TPO antibodies tend to have higher levels. Pregnancy, as we know, the effects of beta-HCG and the effects on the thyroid carrier proteins, their thyroid function tends to be different. A number of drugs and illnesses, which I won't go into today because we have others, more eminent people who are going to talk about this. And there are intra and inter-assay differences between the reference ranges and the actual assays themselves. So the other thing to keep in mind that TSH levels can and do normalize over time. So in this study from Birmingham, over 12 months, approximately 50% of people on the placebo group who initially had hypothyroidism, a TSH of 6.6, 6.7, went on to have normal TSH levels at 12 months. So approximately half the people with marginally raised TSH will normalize. There are certain factors that predict who will and who won't. So for example, people with positive TPO antibodies tend to remain elevated. People with higher TSH levels tend to remain elevated, but the others can and will normalize their TSH over time. So about a third at 6 months and about half at 12 months is what is generally seen. What is important and a fact is that the prevalence of the proportion of people we are treating is increasing year on year on year. This is the data for the UK, and we had data only until 2014 here, until this data wasn't routinely collected. And we can see that from 2005, where roughly 2.4% of the population of the UK was treated with levothyroxine, in 2014, approximately 3.4% of the population, which equates to about more than 2.5 or around 2.5 million people being treated with levothyroxine. Now that's adjusted for the various factors that might impact on this. So independently of those, there's a significant increase on year-on-year increase in the number of people we are treating. And there's a lot of data, certainly from the general practice, that suggests that the threshold at which we are starting to treat people, both in the UK and elsewhere in Europe, is lower now. So say, for example, 10, 15 years ago, if you're treating TSH levels of 9 or 10, they're tending to be more quicker in treating much lower elevations of TSH, levels of 5s and 6s and 7s. We tend to treat these days. So then the question comes to, how do we treat? So once we have diagnosed hypothyroidism and we've decided that this person needs treatment, how do we treat them? The aim of treatment is to improve symptoms, the symptoms of hypothyroidism. And we'll come back to this point again. How easy is it to understand the symptoms of hypothyroidism and ensure that they improve? The other aim of treatment is to achieve normal serum TSH levels. This is relatively, and I say relatively with abundant caution, is that this is relatively the easier thing to do. And this is usually achieved by replacing the thyroid hormones with levothyroxine, and we ensure that by giving the prodrug to T3, the body's internal mechanism, that's deiodinase 1 and 2, convert the T4 to T3 as required within each tissue. The usual replacement dose of levothyroxine is about 1.6 microgram per kilogram of body weight. Are all patients satisfied with levothyroxine? I'm sure as your experience will inform you, as it does mine, and certainly in the literature, and there's a lot more data about this, is that not everyone is majority, around 80 to 90% of people will be fine with treatment, but there's a good proportion, and possibly increasing, that say that they are not happy with the treatment because it doesn't really improve their symptoms. The question is, why is that? And people have been thinking about this over many decades now, and I know we're before in T3, so I won't go into that aspect of it. But it could be that because of our propensity to start treating much lower TSH levels, it may be that the symptoms that people had were never related to the thyroid disease in the first place. By replacing the levothyroxine or by replacing with thyroxine, we are normalizing TSH, but we may not be addressing the initial reason for their symptom in the first instance. So imagine a patient who complains of fatigue, and they might have fatigue because they are obese, and obese, as we know, because of multiple reasons, including cardiovascular compromise, including obstructive sleep apnea, and so on, can cause fatigue. Now, their TSH levels tend to be higher anyway. The patient comes to us, we measure the thyroid function, the TSH is 6, and we assume, or the patient assumes, that it's all done to hypothyroidism. We start treating them with decent doses of levothyroxine. We normalize the TSH and their obesity doesn't really get better. They might lose 1 or 2 kilograms at most, but it's not going to improve their body mass index or return it back to the normal weight category. So therefore, the symptoms are unlikely to change. So it might be that we are treating the wrong group of people in the first place and expecting for symptoms to improve when it was unrelated to the thyroid disease is unrealistic. What about this aim of trying to achieve a normal TSH? Again, that, as I said before, is the relatively easy aspect, but it's not completely normal because as we see from a number of studies, approximately 15 to 20% of people have evidence of low TSH whilst they're on levothyroxine. And again, 20 to 25% of people will have evidence of a high TSH while they're on treatment with levothyroxine. So again, it suggests that for all sorts of reasons, and we'll come back to this in a minute, achieving normal TSH levels in all our patients is not possible. There are a number of reasons why that might be the case. Why is it important to try and achieve a normal TSH? The study from the UK general practice, I think it was the THIN database, which is an electronic patient database of records from primary care patients, was assessed by this group, and I think Christine was a part of this research groups and this paper. And what they observed is that ischemic heart disease, stroke, mortality, fragility fractures, atrial fibrillation, all fractures were all kind of related to the level of TSH that was seen. I stress here, this is observation, this doesn't mean causation, but what you can see is that people with higher TSHs tended to have the worst outcomes. Normal is 1, anything less than 1 suggests better, anything greater than 1 suggests a higher risk. So as you can see here, the risk for mortality, for example, anything greater than, say, 4.5 or so, you'll see that the risk of mortality seems to be higher. The same thing for atrial fibrillation, you'll see that TSH that's below 1 tends to have higher risk, and ischemic heart disease, again, the risk tends to be higher, and so on. So you'll see that this is, again, now this could be many reasons for this. It could be that people who are not concordant with their medications also tend to have erratic lifestyles. It may be that these people who have a higher TSH might have other risk factors that put their health at risk. So it isn't a causal relationship, but it kind of reinforces the fact that aiming for a TSH level that's within the reference range should be aimed for. But again, I stress that we don't have definitive evidence that this is indeed the case. Some risk of overtreatment, possibly. This is from the study that we did looking at the prevalence of hypothyroidism in each area of the UK. And what we found is that the areas where hypothyroidism was much more prevalent, and by that they were more likely to be treated with levothyroxine, those areas were also at higher risk of atrial fibrillation prevalence. Again, I stress this is not a causal relationship, it's an observation. We tried to adjust for a number of factors like ischemic heart disease, like age, like cigarette smoking, and so on. So all the usual risk factors for atrial fibrillation. But despite all that, we could see clearly that in the areas where more people were being treated with levothyroxine, the risk of atrial fibrillation was also higher. Now, if we assume that there's a causal link, then there could be at least two explanations to this. One is, of the people that are being treated, a certain proportion are being overtreated with getting a low TSH, and those people at higher risk of getting atrial fibrillation. The other possibility is that a lot of people who are being treated or who are being started on treatment didn't actually require levothyroxine in the first place. So, for example, a person who is 80 or 85 with a mildly raised TSH of, say, 4.5 or 5, which might be normal for them, and we are starting treatment based on, say, symptoms of tiredness, and we treat them with full dose levothyroxine, and actually the high amount of thyroid hormones is causing the higher risk of atrial fibrillation. Again, these are all assumptions. We do not really know exactly what's going on, but just kinds of tells you that levothyroxine isn't a benign drug that we can give out and not expect possibly long-term consequences. There are a number of other causes of inappropriate levothyroxine dose. Poor compliance tend to be the most common. And again, you can kind of understand this because this is a drug that has to be taken every day for the rest of their lives, much like medications for blood pressure. People forget, people have different lifestyles. Plus the advice to take it an hour or at least half an hour before food, not with this medication or that medication, makes it kind of more complicated. And at least expecting it to happen every day forever is unrealistic. But that could be the most common reason for abnormal TSH levels in people on levothyroxine. I've touched upon this effect of food and other drugs. I won't go into all the detail, but calcium, iron, PPIs are drugs that are generally well recognized to affect thyroid function in people on levothyroxine. Certain foodstuffs such as soya is well recognized. The timing of administration is less of an issue. Some people advocate that taking the levothyroxine at night may be better. It doesn't really matter. I think as long as people can try and keep to that half an hour to 1 hour gap between the levothyroxine and the food, I think that's fine. Specific populations might require different dose, and the best example is pregnancy, and I know we're going to talk about that later, so I'm not going to go into that in detail. Absorption problems, gastrointestinal disease are again common causes, or can be common causes where the absorption of the levothyroxine isn't happening very well. Now, something that we don't really think about very much is the inappropriate storage of levothyroxine and switching between levothyroxine products. These are also recognized to have a role, and we'll talk about that in some detail now. So the factor that affect the stability of levothyroxine is the excipients. Excipients are the inert chemical substances that are added to make up the bulk of a medication, like methyl cellulose or starch. These are inert, inactive, but in certain parts, it can affect the stability of levothyroxine. The packaging, generally airtight and light resistant containers are better than a blister pack. Temperature, ideal temperature for levothyroxine is 15 to 20 degrees Celsius. Now imagine if you keep this outside in say, Iceland in winter, it's not going to be 15 degrees Celsius. It will be low. That can affect its stability. Or keeping it outside in, say, the Middle East in the peak of summer, when it's going to be at least 50 degrees Celsius, it's again going to affect the stability of the product. Humidity has an impact. So if somebody keeps a levothyroxine in the kitchen, where there's a high degree of humidity, or in the bathroom, where the temperature will be high, where the humidity will be high, and it's exposed and it's not airtight, then that can affect the stability. Oxidation, so being exposed. If you keep the tablets outside and take one every day, it's going to have an effect because oxidation will reduce the amount of active drug. Light can increase the degradation of the active compound, and therefore light-resistant containers are better. So these are something we don't really think about very much when we are looking at reasons for why somebody's TSH might be low or high, and they say that they have been taking the medications every day. The other aspect is that different formulations made by different companies might differ slightly. So brand A might make 100 microgram of levothyroxine and brand B might make 100 microgram of levothyroxine. But because 100 microgram can never exactly be 100 microgram, because the regulators do allow a degree of variation. So 95 to 105 is the current recommendation. So 100 microgram tablet can be 95 microgram or 105 microgram. So imagine one brand might have 105 microgram while the other might have 95, and that's absolutely fine and legal. But if somebody keeps taking 105 for a month and then takes 95 for the next month, they're getting 10 micrograms less the following month, or they're still on 100 microgram. So that might have an impact on this. Plus, it also depends on when the batch was manufactured. So if it was manufactured yesterday, they might have a higher amount, so it might have 105 microgram, whereas if it was manufactured 2.5 years ago, it might have closer to 100 or even less micrograms of ingredient within that tablet. So just some things to keep in mind. This question, again, isn't easily answered about who should be treated. It depends on the individual. It depends on your practice. It depends on the person sitting in front of you. But no one would disagree that overt hypothyroidism should be treated. Subclinical hypothyroidism, we've talked about this previously. There is a lot of debate about this and who or which groups of people should be treated at what levels. And again, we agreed that there's no one-size-fits-all criteria for this either. Plus, we also know that there are variations in practice based on geography and various specialties. So, for example, a lot of people in North America may tend to treat subclinical hypothyroidism treatment with levothyroxine than they otherwise would have. And obstetricians and gynecologists come to mind in pregnancy. But again, I'll let Elizabeth talk about that more. So the guidelines from the European Thyroid Association about who should be treated are fairly the most this, and that's why I've chosen them to start with. So based on the age, less than 70 or more than 70, and based on the level of TSH, we should be guided. In the younger group, if they have symptoms, then a 3-month trial should be tried if the TSH is less than 10. If in the older group, then only consider treatment if the TSH is greater than 10, and if they have very clear symptoms of hypothyroidism without no other obvious cause, or they might be at high vascular risk. What about the American Thyroid Association guidelines? They have been around for a while now, close to nearly 10 years, and they are kind of similar, but there is a slight difference in wording, so which I'll try to highlight. So serum TSH greater than 10 should be considered for treatment. TSH levels between the upper end of the reference range of TSH and less than 10 should be considered for treatment if they have symptoms, if they have positive TP antibodies, or evidence of atherosclerotic cardiovascular disease, heart failure, or risk factors for these diseases. Now, if you consider this, there's no criteria about age, but what it does say, they have symptoms suggestive of hypothyroidism. And I think it goes back to the point about what are the symptoms of hypothyroidism. It's very difficult to be certain. What about risk factors for these diseases? A large obesity is a risk factor, hyperlipidemia is a risk factor, hypertension is a risk factor, type 2 diabetes is a risk factor. And we start checking, because if we're saying they should be considered for treatment, if we start checking these groups of people, then we'll find a significant proportion of these will have slightly raised TSHs, and we then start treatment. It probably accounts for why there is a higher prevalence of levothyroxine treatment in the US than elsewhere. So what about selected groups of patients? Extremes of age, pregnancy, cardiovascular disease, and the critically ill. There might be others, but for reasons of time, I will rather just go with these for now. Under the age of 2 years old, levothyroxine should be considered if the TSH is greater than 20, or if the TSH is between 10 and 20 on 2 separate occasions, 3 months apart, or if the TSH is between 5 and 10 on 2 occasions, and they have thyroid dysgenesis or signs or symptoms of thyroid dysfunction. And under the age of 2, consider levothyroxine for children aged between 28 days and 2 years with subclinical hypothyroidism whose TSH is greater than 10. These are the nice 2020 guidelines that I quote here. In older adults, again, I go back to the ETA guidelines. We've talked about this, so I won't go back through this again, but again, about the age of 70, look at the TSH level greater than 10, then consider treatment. What about high risk of in other older people with cardiovascular outcomes? I'll whiz through this, but what it basically tells you is that in older people, no group within this or subgroup within the older people from the TRUST trial subgroup analysis suggests that they are at higher benefit of treatment with levothyroxine as far as cardiovascular outcomes are concerned, or cardiac function for that matter. Doesn't seem to be an effect of treatment of subclinical hypothyroidism in older adults, or carotid intermediate thickness didn't improve, although the TSH levels came down. Again, you'll see there's no improvement in CIMT. Also, patients with acute myocardial infarction, there's no effect of treatment with levothyroxine on their left ventricular ejection fraction, and therefore this is not supported to be treated in these acute MI patients over 12 months. So across a wide number of patient groups who we would think would tend to gain the most if there was any benefit, you would probably do not see the perceived benefit at least over 12 months or so. What about intensive therapy unit patients? There will be no RCT performed to assess outcomes of subclinical hypothyroidism in critically ill patients. What about just non-thyroidal illness? Again, there is no evidence to suggest at least there have been 2 or 3 randomized controlled trials that have tried to use T3 therapy in these very unwell patients, and outcomes were not different. However, if you have somebody who's already on thyroid hormone treatment for hypothyroidism, it would make physiological sense to try and optimize the thyroid hormone levels in the first instance in this high risk group of patients. So in summary, there's scarce data on the prevalence of hypothyroidism in the Middle East, but it's probably similar to most other places in the world, I would suggest. One-size-fits-all policy should be avoided, and treatment should be tailored for an individual. Both under and over treatment are associated with adverse clinical outcomes, including major events, and therefore should be avoided. And the aim should be try and aim for a normal TSH. And diagnosing, managing vulnerable patient groups requires skill and experience, and should therefore be managed by specialists who know what they are doing, and that is by endocrinologists. So thank you very much for your attention, and I think we'll have questions at the end. Thank you.
Thank you, Dr. Razvi, for a comprehensive review of hypothyroidism treatment. And we'll leave the questions to the Q&A session. Now we are moving to the second talk in this program, and the title is Drug-Induced Hypothyroidism. Our speaker is Dr. Christine Bollard. She's a professor of endocrinology at University of Birmingham and consultant endocrinologist at University Hospitals Birmingham. Her clinical research interests include management of thyroid dysfunction, nodules, and endocrine disorders in pregnancy. She is the clinical lead for the NICE guidelines on thyroid disease, the National Consensus Statements on Management of Thyroid Cancer, and the RCOG Green Top guidelines for management of thyroid diseases in pregnancy. She's a senior editor for Endocrine Connections and the BMC Endocrine Disorders, and she serves on the editorial board for many other journals. We'll turn to Dr. Bollard to hear her presentation on drug-induced hypothyroidism.
Good evening, ladies and gentlemen. Thank you for that kind introduction, and thank you for the organizers for asking me to speak on drug-induced hypothyroidism. I have no conflicts of interest to report. So as an overview of what I'll be talking about in the next half an hour or so, I will be highlighting a number of mechanisms of drug-induced hypothyroidism, and then in particular highlight a number of commonly used drugs and the mechanisms by which they affect thyroid function. So medications can inhibit the synthesis or release of thyroid hormones. They can affect immune mechanisms. They can cause ischemic effects on thyroid functioning. They can inhibit the synthesis of TSH. And then there are a number of drugs that interact with levothyroxine absorption and metabolism. So drugs that inhibit the synthesis and release of thyroid hormones, there are multiple, but the ones that I'll be highlighting particularly will be lithium and a little bit about amiodarone, although I did discuss that in my previous webinar. Things such as interferon alpha, interferon beta, and interleukins affect thyroid function through inducing different immune mechanisms. Thyroiditis can be caused by a wide variety of drugs, and this can be through cytotoxic, immune dysregulatory, or ischemic mechanisms. Tyrosine kinase inhibitors are commonly used in cancer, and they do affect the thyroid gland by causing ischemia. Ixarotene is a particular drug, is a retinoid drug that inhibits synthesis of thyroid hormones. And then my final slides just highlight a few things related to drug interactions, although this was already discussed in detail by my colleague in one of the first webinars. So I'll start off with the inhibition of synthesis or release of thyroid hormones. So as we all know, lithium has been used for many decades now to treat uni or bipolar depression. It's also used in the prophylaxis of the bipolar disorders and can be used in acute mania. And it is a mood stabilizing drug which has a very complex mechanism of action. So it tends to accumulate about 3 to 4 times higher in the thyroid than in the plasma. And it has a number of effects on thyroid function. It inhibits the synthesis of colloids. It changes thyroglobulin structure. It weakens the iodination and coupling of tyrosine residues, and it inhibits deiodinase enzymes. And that is illustrated in this cartoon here. So lithium will be taken up by the sodium iodide importer here, and therefore you get this very rapid accumulation of lithium into the thyroid gland. In order to synthesize thyroid hormones, and I won't go into too much detail here, but like I said, it has effects on thyroglobulin synthesis, and in particular has effect on the functioning of the thyroid peroxidase enzyme, which is responsible for iodination and coupling of tyrosine residues. It is also involved in thyroglobulin proteolysis and inhibits things there. So a wide variety of actions by which lithium may affect thyroid function. Now, of course, lithium has a number of effects on a number of organs, and these are listed here. Of particular interest today are the effects on the endocrine system, the effects on the thyroid gland, where it may cause goiter, hypothyroidism, and in very rare occasions, hyperthyroidism. You may also get problems with calcium metabolism, and hyperparathyroidism induced by lithium has been described. I will not dwell on the other side effects of lithium. So how common is this? Well, it occurs in about 14% of women and 4.5% of men who take lithium. And it is clear that whilst this is mainly an effect through synthesis of thyroid hormones and through inhibition of iodine uptake, that antibodies also play a role, and both anti-TPO and anti-thyroglobulin antibodies have been shown to play a role. Often it appears in the first few months after treatment, but it has been described many, many years after lithium was initially started. It is about 5 times more common in women than in men, and it tends to be more common in areas of iodine deficiency. And it is clear that those with pre-existing autoimmunity are predisposed to getting lithium-induced hypothyroidism. So this was a meta-analysis published in The Lancet a number of years ago now that looked at a wide variety of case control studies and the effects that lithium had on various organs. This forest plot here illustrates the effects of lithium-induced hypothyroidism, and you can see that there was a significant effect here when the meta-analysis was performed, with an odds ratio of lithium-induced hypothyroidism of about 6.05, and this was highly significant. So how do we monitor lithium toxicity? Well, as we are all aware, lithium has a very narrow therapeutic index, and once lithium is started, it is important to monitor levels weekly until we reach a steady state concentration, and then these intervals can be increased. It is important to physically examine the thyroid gland and measure thyroid function prior to starting lithium. And also, I suggest that we should measure anti-TPO and anti-thyroglobulin antibodies. We know that lithium may induce antibodies and that lithium toxicity is more likely in those with pre-existing autoimmunity. So it's therefore important that we have a baseline. 6 to 12 monthly monitoring of thyroid function is needed. And the treatment of lithium-induced hypothyroidism is with levothyroxine. So when this occurs, levothyroxine should be started. And levothyroxine is the mainstay of treatment of most drug-induced hypothyroidism. It has to be noted that levothyroxine can often be stopped after lithium is discontinued. So we've discussed lithium effects on inducing hypothyroidism. However, it has a number of other thyroidal effects. It's been known to induce goiter, and as we've already discussed, it may affect thyroid autoimmunity with induction of antibodies. More rarely, in 0.1 to 1.7% of patients taking lithium, hypothyroidism occurs. So this can either take the form of a thyroiditis or can herald the co-occurrence of Graves' disease. It is important that lithium may also have a number of therapeutic effects, and indeed in the management of some thyroid discussions is used therapeutically. It can increase the ability of the thyroid gland to take up iodine by about 30%, and this can therefore be useful in treating amiodarone-induced hyperthyroidism. In a number of studies, it has been used as an adjuvant treatment for radioactive iodine, as it increases the effective half-life of iodine, and that is illustrated here. You can see that compared with patients who received just radioiodine, those patients who were pre-treated with lithium and simultaneously to receiving radioiodine had lithium, that the percentage of patients that were cured following radioiodine went up significantly. So another drug that may affect iodine uptake or has a number of effects through iodine is amiodarone. And these are slides that I showed in my previous webinar, so I won't dwell on it too much. But just to remind ourselves that amiodarone has 2 main effects, whereby it determines thyroid function. It has a number of iodine-related effects, and then mechanisms not related to iodine. The iodine-related mechanisms are either the Wolff-Chaikoff effect or the Jod-Basedow effect, and it is this Wolff-Chaikoff effect that I'm mainly talking about in this context here, as if there is a failure to escape from this inhibition of iodine organification, hypothyroidism will remain. It is, of course, also possible that amiodarone induces a destructive thyroiditis and that hypothyroidism ensues. As you are aware, amiodarone also has a number of cytotoxic effects on the thyroid gland, which may present itself initially as hyperthyroidism, but often hypothyroidism will ensue. So in patients on amiodarone, there are a number of thyroid function test changes. There are some related to short-term therapy and then to longer-term therapy. TSH is often increased initially, as is T3 and T4. as is T4 and reverse T3. With long-term therapy, often thyrotropin is normal, thyroxine will be slightly increased, and T3 will be slightly decreased. Reverse T3 is not something that we routinely measure in clinical practice. So how do we manage amiodarone-induced hypothyroidism? And I'd like to take you to the left-hand side of this slide here. I already discussed this in my previous webinar, the right-hand side. So in patients taking amiodarone, 10 to 20% will get amiodarone-induced hypothyroidism. And once this ensues and is confirmed by a high TSH, a low free T4, and a low total of free T3, levothyroxine should be started in the standard way, and patients should then be followed up. I'm usually a little bit more cautious about the dose of levothyroxine I start in patients who have significant underlying heart disease, as these patients on amiodarone will be. Moving on then to a second mechanism, which is mediated through affecting immune mechanisms. And the drug I would like to discuss here is interferon alpha. So interferon alpha used to be quite widely used for the treatment of hepatitis C. We now have a number of better antiviral treatments, but it is still used in a number of patients. Now, hepatitis C per se can be associated with thyroid autoimmunity, and both Hashimoto thyroiditis and Graves' disease has been described in patients with chronic hepatitis. We know that in patients who receive interferon alpha for hepatitis C, 2 to 48% of them will have thyroid antibodies. And this here again is a systematic review that looked at this, where you can see that anti-thyroglobulin antibodies were significantly higher in patients with hepatitis C. And this was also the case for anti-TPO antibodies. And this was in patients before they started interferon alpha treatment, so in interferon alpha naive treatments, patients. Hypothyroidism is also common in patients infected with hepatitis C virus, and you can see here that hypothyroidism, when all these various studies were looked at together, that the risk of hypothyroidism was significantly higher. It is important to note that when interferon alpha is used for cancer treatment, the induction of thyroid dysfunction is different. So it appears that this chronic inflammatory disease from having hepatitis C plays an important role here. It is important to check thyroid antibodies and TSH measurement before we start interferon alpha treatment. If antibodies are positive, it is recommended that you monitor TSH2 monthly, and if antibodies are negative, that you monitor this 6 monthly. So what are the mechanisms involved here? Well, there is an activation of a number of intracellular signaling pathways, and I won't go into the detail of this as this is quite complicated. It is known that if autoantigens are present and there is higher exposure of interferon alpha, that thyroid damage is promoted. A number of immune cells, including natural killer cells, will be recruited in this inflammatory reaction. But interferon alpha also has a direct cytotoxic effect. 20 to 40% of patients started on this drug will develop thyroiditis, and 5 to 20% will get overt thyroid dysfunction. As is usually the case in thyroid disease, this is more common in women, and it appears that some people have a genetic predisposition to getting this. Those with underlying autoimmunity will be more likely to get interferon alpha-induced thyroid dysfunction. So this was a study here that looked at patients, 242 patients, that were treated with a combination of interferon alpha and ribavirin. And you can see that the things that were identified as risk factors for developing thyroid dysfunction was the type of interferon alpha that was used, a higher level of TSH, as well as the presence of thyroid antibodies. So if these were present, then the odds ratio of developing thyroid dysfunction was significantly higher. In this study, it was identified that thyroid dysfunction occurred in 27% of patients and 10% of them required treatment. Important, and this is not just related to interferon alpha, but often when thyroid dysfunction occurs, then the drug actually works better. And we know that patients taking interferon alpha will have a more sustained viral response if they develop thyroid dysfunction. Moving on to the next type of mechanism then, and what I'll talk about here is tyrosine kinase inhibitors, which are widely used in the treatment of cancers. You can see here a number of tyrosine kinase inhibitors, as well as the targets on which they act. And essentially, this is mainly affecting angiogenesis, and it's the vascular endothelial growth factor that is affected, although a number of very related factors, fibroblast growth factor, epidermal growth factor receptor, are all targeted by these various drugs. And it is essentially the RAS and the PI3 kinase pathway that will be affected by these drugs and thereby induce its anti-cancer effects. The human diseases in which this is used are metastatic renal carcinoma. We use it in advanced radioiodine-resistant differentiated cancer, but also in medullary thyroid cancer, in hepatocellular carcinoma, and in a number of gastrointestinal tumors. And this is one of the first studies that looked at the use of these tyrosine kinase inhibitors, comparing sorafenib and sunitinib, which are two different tyrosine kinase inhibitors in patients with metastatic renal cell carcinoma. So this was 73 patients, and you can see that sunitinib caused a significant increase in TSH rise, so in inducing hypothyroidism, as compared to sorafenib, which is the black bars here. We know that progression-free survival was significantly better in those patients who developed thyroid dysfunction. This is similar to what I illustrated with interferon alpha, which was this, if you induce thyroid dysfunction, then actually the therapeutic effect of the drug is better. So you can see here the progression-free survival in those patients who developed normal thyroid function, and then in those patients who developed hypothyroidism, this was much better. Similarly, those patients whose thyroid function was changed during follow-up had significantly better survivals. So sunitinib seems to be doing this much more prominently than sorafenib, as is illustrated here. So with sunitinib, the risk of hypothyroidism estimated to be 14 to 70%, and it increases with the longer duration of treatment as well as the number of cycles. Often it occurs early, within 4 weeks, but it can occur many weeks after. And again, that use sunitinib, you can see that for all grades of thyroid dysfunction, there was a significant risk. And for high grades, so this is significantly raised serum TSH, again, this forest plot indicates that the relative risk was nearly 5 times. So what are the mechanisms involved? Well, we know another of tyrosine kinase inhibitors will also induce thyroid dysfunction. In sorafenib, that's up to 27%, axitinib 21%, and pazopanib less than 12%. And this is mainly ischemic effects. Like I said, these tyrosine kinase inhibitors affect vascular endothelial growth factor and similar receptors, and it is their effects on the thyroid are due to anti-angiogenesis. You'll get impaired vascularization and thyroid ischemia, and there is also an impairment of the compensatory mechanisms that would usually ensue. We know that a rapid reduction in vascular flow through these agents may cause an ischemic thyroiditis. We know that in patients who have pre-existing hypothyroidism, the use of tyrosine kinase inhibitors will make that hypothyroidism worse. And of course, this cannot be due to angiogenic effects on the thyroid, because there is no thyroid, but it appears that these agents also stimulate the deiodinase 3 enzyme, and that there is reduced activity of the deiodinase 2 enzyme. So how do we manage this? Well, again, it's important to measure serum TSH before you start tyrosine kinase inhibitors, and that this is monitored every 2 to 3 months, or obviously sooner if the patient develops clinical signs of hypothyroidism. It is not recommended to routinely measure antibodies, as this is one type of drug where this does not appear to be related to thyroid autoimmunity, but that you monitor TSH 3 monthly, certainly if pre-existing hypothyroidism is there. Like I said, in those patients who are already hypothyroid, often, excuse me, often adjustment to levothyroxine dosage is needed. So similarly to non-drug-induced hypothyroidism, you would start levothyroxine if TSH is over 10, and certainly if the patient has symptoms or evidence of thyroiditis on an ultrasound, you can start this at lower levels of TSH. And again, often after discontinuation of tyrosine kinase inhibitors, levothyroxine may be stopped. A further mechanism is then a central mechanism on TSH synthesis, and this is seen with some of the retinoid drugs. So treatment of retinoids is still used in T-cell lymphoma, And retinoids essentially, or these drugs are essentially selective agonists of the RXR receptor. And just a little bit of basic science detail here. But so this cartoon illustrates the uptake of thyroid hormones into the cells and then cellular effects. And you can see that both T3 and T4 are taken up by specific receptors, including MCT8. You then have effects of deiodinase enzymes. T3 will go into the nucleus, bind to the thyroid receptor, which dimerizes with RXR, and this is how thyroid hormones have their effects. Now, bixarotene has a number of effects on the thyroid gland. The most pronounced ones are the central effects. So it's possible that it reduces TRH production, but its main effects are on TSH. So it reduces TSH gene transcription and also has effects on the deiodinase 2 enzyme. There are a number of peripheral effects of bixarotene, including increased liver D1 expression, as well as a transactivating effect of permissive dimers. So T3 has a negative feedback effect on the transcription of the TSH beta subunit in patients treated with bixarotene. And due to this altered feedback effect, there will be reduced TSH gene expression and transcription. There is also evidence that there is direct inhibition of TSH secretion, and even after a single dose of bixarotene, there will be a rapid fall in TSH. Central hypothyroidism is described in up to 100% of patients treated with this drug, and usually after you stop bixarotene, serum TSH will normalize quite rapidly. 90% of patients will have long-term euthyroidism after retinoid is discontinued, and it appears that some of the effects are dose-related. So the higher the dose, the more likely or the more severe the hypothyroidism is. So this slide here illustrates a study looking at the central effects of bixarotene. This was 66 patients treated with bixarotene for for lymphoma. And you can see that after 1 week, serum TSH dropped in 45 of these patients. And after 1 month, this was virtually universal with only 5 patients who remained euthyroid. So this induces a central hypothyroidism. And we know that patients who start off with lower TSH and lower 3-4 levels will have more pronounced and are more likely to have these effects. Bixarotene also has a number of peripheral effects, and this was a study looking at 10 patients who were treated for metastatic differentiated thyroid cancer, where bixarotene was used to see if uptake of radioiodine could be improved. And you can see that there were effects on peripheral degradation of all thyroid hormones. So when you can see at baseline and then following treatment, the levels of total T4, free T4, and free T3, and these were all significantly reduced. So central as well as peripheral effects of bixarotene. So both tyrosine kinase inhibitors and bixarotene are widely used in cancer treatment. And so this slide here illustrates what the recommendations are to manage these patients. So if you start tyrosine kinase inhibitors, in new thyroid patients, you measure TSH at initiation and then monthly or on the first day of the new cycle for the first 6 months. Thereafter, TSH every 3 months, but of course, you are guided by patient symptoms. If a patient has pre-existing hypothyroidism or has been thyroidectomized, you monitor TSH monthly for the first 3 months and then 3 monthly throughout the therapy periods. So treat TSH if it's over 10 or if it's lower in patients who have symptoms or who have antibodies or autoimmune thyroiditis. And generally, replacement dose would be between 1 to 1.6 micrograms per kilogram. Patients starting on bixarotene, you should measure TSH and free T4 at initiation. And then if central hypothyroidism ensues, you start levothyroxine at 25 to 50 micrograms. And usually, actually, when you start bixarotene treatment, it is advisable to give levothyroxine alongside it, because we know that up to 100% of patients will develop hypothyroidism. You're then guided by free T4 levels, because of course TSH will be uninformative in these patients with central hypothyroidism, and you adjust those to maintain free T4 in the upper third of the normal range. Then once free T4 levels are stable, you can monitor it monthly, and you it's advised that once bixarotene is stopped, you remeasure thyroid function and consider stopping the treatment. In patients who have prior hypothyroidism, increase the levothyroxine dose. This can increase up to 3 times, and again, be guided by 3 to 4 concentrations. So finally, then, a number of drug interactions with levothyroxine. Like I said, this has already been addressed in one of the first talks where we talked about interpretation of thyroid function tests, but essentially a number of drugs interact with both the absorption and metabolism of thyroid hormones. So a number of drugs, including proton pump inhibitors, calcium carbonate, ferrous sulfate, are drugs that interact with the absorption of levothyroxine. So this may be important, for example, in pregnant women, where I tell those who are taking levothyroxine, if they require iron, which is often needed in pregnancy, that they should take this at least 4 hours apart, as absorption of levothyroxine may be affected. We also know that a number of nutritional habits that affect absorption of levothyroxine. So again, patients who start levothyroxine are advised to take this first thing in the morning without any tea or coffee for at least an hour. And we know that things such as orange juice will also affect the absorption of levothyroxine. What about thyroid hormone transport and metabolism? Well, again, a number of drugs can affect this. So estrogens will induce increased hepatic synthesis of thyroxine binding globulin, as well as the glycosylation of this. And so at certain stages in life, they can have important roles. So we know that this plays a role in pregnancy, but also menopausal women who are started on HRT or people taking the oral contraceptive pill, we may have to adjust the dose of levothyroxine that we take. A number of drugs listed on the left here that are used in the treatment of epilepsy affect the intrahepatic deiodination of thyroid hormones. They activate CYP33A4, and they also affect the conjugation of sulfate and glucuronic acid and induce enzyme. So again, these drugs may affect those of levothyroxine that we give and may cause hypothyroidism. And then heparin, a caution here that this may result in difficulties in interpreting thyroid function tests. So to conclude, many of the drugs used in routine clinical practice can cause hypothyroidism. A number of them have distinct mechanisms, but often mechanisms overlap. Thyroid autoimmunity, as always in thyroid disease, plays an important role and may actually be induced by a number of these drugs. It is important to assess thyroid status as well as antibody status prior to starting drugs that are known offenders. Regularly monitor thyroid function if you know that the patient is taking a medication that may affect it. Start timely replacement and adjust doses of levothyroxine as needed. And bear in mind that the hypothyroidism is often not permanent. Thank you very much for your attention.
Many thanks, Dr. Bollard, for a very informative talk. Before we move to the third talk, I'd like to remind our audience to send their question and type them in the Q&A section. We have 4 experts in thyroidology, and I'd like to ask you to take this opportunity to ask any question, or if you have comments or you have challenging cases you want to discuss, please type in the Q&A section. Now we're moving to the third talk. The title is Unhappy Thyroid Patient, T3, T4 Combination. The presentation will be by Dr. Alex Tisno. He's Associate Professor in the Department of Internal Medicine at UT Southwestern Medical Center. He specializes in thyroid nodules and thyroid cancer. And he has delivered several invited lectures and published numerous academic articles. And welcome, Dr. Tisno. You can share your slides.
Thank you. Hopefully you can hear me okay. I'm going to, let's see if I can pull. I'm coming to you live from Dallas. Thank you for having me. And let's see if I can pull up We're going to get started here. Okay. Thank you. I'm happy to be your Friday evening entertainment. Well, it's Friday morning here in Dallas, but anyway, I wanted to talk to you a little bit today about the role of combination therapy and, does it really help? I mean, so I wanted to just start with, what we've talked about previously, which is just the impact that hypothyroidism has in the world, really. And when we look, of course, across the age groups, women predominate men in terms of abnormal thyroid function tests, with this being from the Colorado Health Study, showing that the prevalence of TSH elevation increases with age, and of course, even more so among our female patients. This is data I pulled. This is interesting, and I'm sure it's similar in other countries, but in the United States, the blue states are the states in which levothyroxine is the most commonly prescribed medication. And so you can see the predominance of that. So, and second to that, of course, is the antihypertensives, and sadly, third is often pain medications. But thyroid hormone is, of course, a very prevalent prescription. The symptoms of hypothyroidism are obviously very well known to us: weakness, constipation, cold intolerance, fatigue. And our goal is, of course, when we treat these patients, that we're alleviating these symptoms. And that's all great. However, a significant percentage of patients, I don't know if you can see this, if I'm blocking. There we go. Maybe blocking the slide points here. But many of our patients who are treated to normal TSH still continue to complain of symptoms of that are compatible with thyroid dysfunction. Now, maybe they're not all related to thyroid hormone. However, when you look at just general quality of life scores via the SCL90 or the RAND scores, and general quality of life, mental health, and vitality, patients who are treated for hypothyroidism often score lower than the general population. And often these symptoms, of course, are very vague. They can be just depressed mood. A lot of my patients call it brain fog. I just don't feel quite 100% there. Is that related to the thyroid or not? So are there other possibilities that could be causing these symptoms that our patients complain about? And so I would just say, we see this in many diseases, but just the perception or the awareness of having a chronic illness sometimes makes patients feel that they're not completely healthy. And so sometimes these scores are not quite as high. There's also the possibility that there's other coexisting autoimmune disorders, as most of thyroid dysfunction is related to autoimmunity. And the inflammatory activity caused by autoimmunity may be, in fact, causing some of these symptoms. We see this in other disease states, such as cancers, where we see a lot of cytokines and other things secreted related to the immune function that may actually be causing some of these symptoms that are actually not related to the thyroid level at all. And, of course, as Dr. Rosby showed earlier, perhaps we're under treating some of these patients. What is the ideal target range in our patients? I'm not going to go into that today. There's a lot of controversy onto that. But should the TSH target range be 4, which is normal range, or most of us generally live within a TSH range of between 1 and 2? Is that the ideal range? So there's two different types of thyroid hormones, of course. T4 is interesting in that it has an extremely long half-life. I mean, it stays in the circulation for up to the half-life being up to a week. And so as a result, it can take 6 to 8 weeks, as you know, to get to a steady state concentration when we treat or we adjust the medication. The full replacement dose being around 1.6 mics per kilo. And there's really no side effects to treating with levothyroxine unless we also under replace our patients with thyroid hormone. In contrast, T3 has an extremely short half-life. It's actually very well absorbed. When we take T3, about 95% of that tablet is completely absorbed. The pharmacokinetics, though, are less worked out, I would say, with the peak typically being between about 2 and 4 hours, and then it generally is out of your system again in 10 to 12 hours. So it has a very quick onset and offset of action, and sometimes this peak, if you will, can cause some of the symptoms of tachycardia, jitteriness, sometimes a little bit of a caffeine rush almost that patients can experience when they take T3. So the first, thyroid hormone replacement we had was pig thyroids. And so this became available in the 1880s. Prior to that, people used to die of hypothyroidism. Now we had a treatment for that. And this was the mainstay of treatment until about the 1960s, when synthetic human thyroid hormone preparations became available. And of course, this is developed by taking pig thyroids from the slaughterhouse, and basically they take them back to a lab, they desiccate them, they powder them, and they compound them to produce tablets. There may be some potential issues, though, of course, to taking pig thyroid products. There are documented cases of allergies to the pork products. There's been a lot of controversy related to the composition of these tablets. Is it always the same from tablet to tablet or lot to lot? But I would say, even more importantly, the T3 to T4 ratio of the pig thyroid is actually not the same as it is in the human thyroid. So the pork ratio, for instance, of T3 to T4 is around 1 to 4. Whereas in the human thyroid, if you were to grind up our thyroids, you would find that our ratio is closer to 1 to 14 or 1 to 13, depending on. So it's not exactly the same, even though some of these products are deemed as quote unquote natural. They're not necessarily natural to the human body. So there may be some issues also with safety with taking pork thyroid products. This is a recent recall from the U.S. Drug Administration related to one company where there was variability in composition of pork thyroid products. So this has been on our minds as physicians when we prescribe these products. However, patients have access to the internet, and there are several thyroid, quote unquote, thyroid groups, if you will, out there that have differing opinions based on differing, I would say, to the quote unquote mainstream party line as far as how we treat thyroid hormone with thyroid hormone. And so one of these is this is one of the popular groups, and they state that when we prescribe thyroid hormone, we're not looking at the whole patient. We're looking at lab work more importantly than their symptoms, and we're sometimes prescribing antidepressants for patients with persistent symptoms rather than treating their free T3. Well, so why is levothyroxine considered the standard of care? Well, this is from the American Thyroid Association, and the recommendations are, well, we know that it works. We have long-term experience since the 1960s, so we have almost 50 years now, 60 years almost of safety of this medication. It's inexpensive. It's easy to take, except I would probably take issue with good intestinal absorption. It's well absorbed if we take it the right way, of course, with water only on an empty stomach. It does have a very long half-life, and that makes it fairly easy to administer, and it works, right? So are the symptoms, though, of hypothyroidism alone enough to gauge adequacy of levothyroxine replacement? Well, as you know, the symptoms of hypothyroidism, quote unquote, tend to lack sensitivity and specificity thereof, and so sometimes those symptoms that patients experience are not necessarily related to their thyroid. So in absence of biochemical assessment, we should follow these symptoms, but to consider them in context, we should consider them in context of the TSH values. Now, when we look at these recommendations, of course, it's a weak recommendation based on low quality of evidence. What's interesting, though, is if you take patients who have had a thyroidectomy, who have no endogenous thyroid hormone production, and we give them T4 only, we see that their free T3 to free T4 ratios are different than in normal individuals. So, and in fact, as the T4 concentration, or I should say dose, increases, that T3 to T4 ratio becomes significantly lower than what the native human thyroid production would be. Now, these are some landmark studies done by a group in Spain back in the 1990s, which showed that when we give when we give T4 only, we don't necessarily approach normal tissue levels of T3 just with T4 only, and it's seen. We do tend to get pretty good T3 production in the pituitary, but not necessarily in other tissues such as the heart. It took actually a combination of T3 and T4 in these thyroidectomized rodents to achieve normal tissue T3 levels. So why is this? Well, in the brain, particularly in the hypothalamus, most of the T3 is derived from D2, the D2 enzyme, which deiodinases T4. And the T4, which is interesting, T4 actually speeds up the degradation of D2. So T4 is an inhibitor of the deiodinase enzyme. In the central nervous system, however, that T4 degradation of T4 of D2 is not as robust as it is in the periphery. So the hypothalamus, in other words, does not show much T4-induced reduction of T3 production, though we do see that in the periphery. So TSH may be suppressed, in other words, while some tissues may still remain relatively low in T3 production. So let's look at this a little closer. So in the periphery, we have T4 being converted to T3 by D2. However, T4 then catalyzes the ubiquitination of D2 enzymes. So ubiquitination is sort of the body signal of saying this enzyme is ready to be degraded. So, so when we see this in the periphery, we might see a reduction in high doses of T4 of T3 production, in other words. Sort of counterintuitive, but that's what can happen. Let's look at the brain, though. So when we talk about, when we talk about in the brain, again, we have T4 to T3 degradation, deiodination, which of course, as you know, suppresses TRH. This, of course, then reduces TSH secretion. This, if we look at the deiodination enzyme, the D2, and we ubiquitinate that, what's interesting is in the brain, there is a separate deubiquitination process that occurs that is not seen in the periphery. So in other words, T3 continues to be produced in the brain, in the hypothalamus, that is, causing suppression of TSH, whereas in the peripheral tissues, we might actually have a lower T3 production. So that's sort of the rationale scientifically as to why these T3 levels may be lower despite a high T4 level. So why not just add in a little bit of T3? So I Googled what hypothyroidism looks like, and this is what I came up with. This is my Google image search. And so let's palpate our submandibular glands while we think about this. So here we are. So here's the rubber meets the road. Let's look at T3, T4 combination trials, and let's see if this works. Well, to date, there have been at least 15 randomized clinical trials that have attempted to address combination therapy versus T4 only in terms of the treatment of hypothyroidism. But what's interesting, as common as this problem is, we only have had, excuse me, my slides are advancing without me. Only about 3 of those trials have had more than 100 patients. It seems to me crazy. And these trials, though, were heterogeneous in terms of the population that was studied. So some of these patients had just hypothyroidism related to autoimmune thyroid disease. Some of them had complete hypothyroidism, as I would say, related to thyroidectomy. And so some of these trials are very heterogeneous. Also, the combinations that were used in these trials are not exactly the same. So when we look at this, we have to look at, so we have to pool this data. And so looking at meta-analyses, so what is the total effect then of combination therapy versus monotherapy in terms of quality of life? And this is a meta-analysis performed of almost 600 of those patients. And as you can see, the line really is on really no change at all. So we didn't really see any benefit in terms of combination therapy related to versus monotherapy in terms of quality of life. So game over, right? So there's no benefit proven. Well, what's interesting though is if you look at those trials a little closer, and these are blinded studies, a significant percentage of the patients actually preferred the combination therapy versus the monotherapy. And people use this data, advocates and people that are against combination therapy use this data the same way. So when we look, if we look at combination therapy patients, well, 48% versus 25% preferred the combination. However, if you look at and you say, well, we're going to add this all together, the people that had no preference, it's a wash. So this brought up the fact, well, maybe there are genetic variants. Maybe there's some people that actually prefer the combination therapy or do better on combination therapy than those than the general population would be. And so let's look at the deiodinase enzymes. As you know, this catalyzes the conversion of T4 to T3. And so maybe there's some variance within those enzymes. And as we know, most of the T3 in the brain comes from D2 type of enzyme. So we looked closer at that. And this enzyme, excuse me, so D2, as you know, is coded by the gene DIO2. And there's a SNP, or a single nucleotide polymorphism, which is, in other words, a mutation, which might alter the conversion of T4 to T3 at the tissue level. And so this would be especially true in the brain, where we see this conversion, which is so important based on D2. And perhaps the quality of life and treatment satisfaction may be affected by some of these genetic variations. So when we look back at the largest community-based trial of combination therapy, we have to go look back at the Suramanen trial from the United Kingdom. And as a whole, when we look at combination therapy, there was really no difference versus levothyroxine therapy when we looked at general health questionnaire scores, particularly at 12 months. There was no difference between the two groups. However, when we looked at this one SNP here, which is present within about 10 to 15% of the population, which causes one amino acid substitution. If you look at the homozygous group on the right, the CC group, there was a statistically significant difference in terms of how they perceived quality of life when they were on combination therapy versus when they were on monotherapy. This was also true when we looked at treatment satisfaction. So treatment satisfaction was much higher in the patients receiving combination therapy if they were homozygous for this particular polymorphism. And it's true that there may be many others that affect the regulation of thyroid hormone metabolism within the brain. There are different channels, of course, which allow the entry of T4 into the central nervous system. And people have been looking at these different potential targets of genetic variations within the population, the MCT8s, the MCT10s, which may in fact alter thyroid hormone perception, if you will, in the brain. But in the clinic, we can't know who these people are. There were no differences even within this the SNP I showed you in terms of T4 and T3 circulating levels. So we can't tell in the clinic. So the only way to know who will, quote unquote, feel better on combination therapy is to do an experiment with combination. There was one head-to-head recently published that I wanted to show you. This was 75 patients who were treated with levothyroxine, had a stable TSH. These were hypothyroid patients. This was a double-blind crossover. And they actually had 3 arms, levothyroxine monotherapy versus a combination with the synthetics versus pork thyroid products. They used Armour brand in this trial. And there was actually, the outcome was there was no difference in terms of the symptoms of hypothyroidism or the neurocognitive function or TSH levels within. It was a very well performed trial. There was no difference in the weight or lipid parameters seen, and there was no difference in patient preference. Most of the patients, symptomatic patients, however, there was, in the most symptomatic patients, there was actually no difference within the mutation I showed you previously. However, some of those patients actually trended towards an improved outcome with combination therapy. So if we look at the general health questionnaires, the thyroid symptom questionnaires, and the Beck depression inventory, the patients who had the highest percentage of quote unquote hypothyroid symptoms actually tended to do better with combination therapy, though this did not reach statistical significance. As you can see, the confidence intervals cross zeros, but there was definitely a statistical trend. So how do we resolve this issue? Well, if we look at the ATA guidelines, they say there's really, the current published guidelines say there's no significant evidence to support a routine trial of combination therapy in patients who are, in other words, dissatisfied with monotherapy. The European thyroid guidelines, though, suggest that combination therapy might be considered on an experimental approach in patients who are treated with monotherapy who still have persistent complaints despite normal serum TSH levels. So sometimes I follow that ETA guideline, and if I do so, I typically would use combination therapy using synthetics because I feel that I can get a little bit closer to the human ratio of T4 and T3 using synthetics. These are some of the examples that I might use if a patient has normal TSH values who continues to complain of thyroid symptoms. I might give them a trial of T4, T3 combination therapy. These are the ratios I typically would use. And so I wanted to kind of leave that here for your reference. These calculations are based on the European Thyroid Association guidelines. So in conclusion, I wanted to say that the minority of individuals who experience a return, there are a minority of patients, excuse me, who do not experience a return to normal, quote unquote, healthy status, even though they have normal TSH values. That's typically in the literature between about 5 and 15% of our patients. Genetic variants may actually play a role in why some of these patients don't feel exactly the same way. But there is controversy as to whether adding T3 or switching to a desiccated thyroid product improves those symptoms or it's safe for chronic use. I would say, though, that monotherapy is, as the only acceptable method of thyroid hormone replacement, is not a proven fact. We definitely need more studies to look at this in terms of how we treat our patients. There are some potential ways we can try this experiment in our patients who continue. However, I would say that this could be done if it's done on an experimental basis. Typically, I will repeat T3, T4 levels, TSH levels in about 3 to 6 months after I initiate therapy. I do not do this in pregnant patients. I don't feel that T3 products are necessarily the best product to use in pregnant individuals. That we'll hear more from Elizabeth here in a moment. And this could be done on an experimental basis. Thank you. I appreciate you allowing me to be here.
Thank you very much, Dr. Tesno. Still a very challenging subpopulation of hypothyroidism that we need to deal with. And I think we'll come later on to the Q&A. Perhaps we can discuss some questions related to the combination therapy. Now we move to the fourth talk about hypothyroidism and pregnancy. It will be delivered by Dr. Elizabeth Pierce. I think we know her in the region, multiple presentation in our endocrine congresses over the last few years. She's a professor of medicine at Boston University School of Medicine in the section of endocrinology, diabetes, and nutrition. She was the 2018-2019 president of the American Thyroid Association. Her research interests include the sufficiency of dietary iodine in the United States, thyroid function and pregnancy, thyroid effects of environmental percolate exposure, and the cardiovascular effects of subclinical thyroid function. I think one important to mention that she is a co-chair of the American Thyroid Association 2017 Thyroid and Pregnancy Guidelines Task Force. So she is the right person to speak to us today about hypothyroid management in pregnancy. We'll turn it over to you, Dr. Pierce.
Hello, it's a pleasure to be with you today, at least virtually. I've been asked to discuss hypothyroidism in pregnant women. And I want to start by just reviewing how we diagnose hypothyroidism and how we define hypothyroidism in the pregnancy setting. Then we'll talk a bit about the effects of the various forms of maternal thyroid hypofunction. So that's overt hypothyroidism, subclinical hypothyroidism, and hypothyroxanemia on both the pregnancy outcomes and child developmental outcomes. And then I'll conclude with current recommendations around treatment. So to start with, thyroid function shifts over the course of gestation. And one of the major drivers of change in thyroid function over pregnancy is HCG, human chorionic gonadotrophin. Recall that that rises in pregnancy until about week 10 or 12 and then declines again. And HCG stimulates the thyroidal TSH receptors. So when HCG levels are high, there will be a concomitant rise in thyroid hormone levels, which then feed back at the hypothalamus and pituitary and cause a decrease in TSH. So in early pregnancy, when HCG levels are high, TSH levels are reciprocally a little bit low. In an ideal world, we would all have access to pregnancy-specific reference ranges that are assay-specific, gestational age-specific, and derived from populations of pregnant women with no known thyroid disease, with no known thyroid antibodies, and with optimal iodine nutrition. Unfortunately, these ranges really don't exist in many places. I don't have access to them clinically myself. And so for most of us, what we're going to be guided by in pregnancy is instead the current guidelines, which suggest that we can take our non-pregnancy upper limit of normal for TSH, and in early pregnancy, that level can be reduced by about 0.5, which puts the upper limit of normal for TSH in early gestation somewhere around 4 for most assays. Now, an important side note to that is that women who are TPO antibody positive may be a little bit different in how they respond to HCG. That's demonstrated by this analysis by Tim Korovar and colleagues, and they looked at the same associations I just showed you between maternal thyroid function and maternal HCG levels, but they did something novel, which was to stratify based on maternal TPO antibody status. So it's done in 2 different cohorts, so essentially the figure is duplicated here, but what you see in the far left of each of these panels is that in the TPO antibody negative relationship, there's a very linear, very positive relationship between maternal HCG and maternal free T4 levels, and a linear inverse relationship between maternal TSH and maternal HCG. Again, what I just showed you and what we've known for some time. What's different is on the right-hand side of each panel, you can see the TPO antibody positive women, and in those women, this relationship really appears to be lost. So there's something about the TPO antibody positivity that seems to prevent women from having normal thyroidal response to HCG. And so that can manifest as a TSH that does not decline normally in early pregnancy, as shown in blue, but instead, as shown in red here, may in fact increase a bit or is at risk for increasing and staying elevated over the course of gestation. A few definitions are important here before we really jump into the rest of the talk. So important to note that currently overt and subclinical hypothyroidism are being defined in the pregnancy setting the same way they are outside the pregnancy setting. Overt hypothyroidism is considered an elevated TSH with low free T4. Subclinical hypothyroidism, that TSH elevation when the free T4 is still normal. And then there's an entity, isolated maternal hypothyroxanemia, that we really only define in pregnant women. And that is a normal TSH with a free T4 that's low, and usually that free T4 is in the bottom 2.5 for a given assay and cohort. These are relatively common in the general pregnancy population. We're not sure exactly how common because over the years, studies have used a lot of different definitions and a lot of different TSH thresholds to define this. But a recent meta-analysis using current definitions suggests that perhaps about 0.5% of pregnant women might have overt hypothyroidism, about 3.5% subclinical hypothyroidism, and somewhere around 2% isolated hypothyroxanemia. And important also always in treating pregnant women to consider what does and does not cross the placenta to the fetus. So in pregnancy, TSH and HCG do not cross to the fetus. Maternal thyroid hormone does, in low but very critical quantities. The fetal thyroid is present by about week 10 or 12 of gestation. It's functioning somewhere around week 16 to week 20. But in that first half of pregnancy, before that fetal thyroid starts to function, the fetus is utterly reliant on the maternal thyroid hormone that does cross the placenta. We think that is largely thyroid, T4, not T3. It's debated whether T3 crosses the placenta to the fetus, but it is actually fairly well established that maternal T3 does not get into the fetal brain where it's needed for brain development. Thinking then about the effects of hypothyroidism in pregnancy. First of all, overt hypothyroidism in pregnancy seems to be associated with a number of really adverse outcomes. So women who are untreated with overt hypothyroidism in gestation are at increased risk for gestational hypertension, for pregnancy loss, for preterm birth, for having children with low birth weight, and for having children with lower IQ. There are no randomized clinical trials assessing the effects of thyroid hormone replacement in overt hypothyroidism in pregnancy. I don't think such trials would actually be ethical, but important to know that we are fairly confident that treatment improves outcomes and that there's really no controversy that women with overt hypothyroidism in pregnancy require thyroid hormone replacement. What is much more controversial is whether or not we should be treating women who are subclinically hypothyroid in pregnancy. And we have pregnancy cohorts now going back a couple of decades that have looked at maternal subclinical hypothyroidism in association with various gestational outcomes. This is one of the first of the big cohorts by Brian Casey and colleagues, 16,000 mother-child pairs here. And they saw that early gestational subclinical hypothyroidism was associated with increased risk for placental abruption, for preterm delivery, and for having children who are at risk for needing admission to the neonatal intensive care unit or for having respiratory distress syndrome. Individual cohorts, though, that have looked at this have had somewhat variable outcomes over time. In 2016, Spiridoula Maraca did a very beautiful systematic review and compiled what at the time were 18 cohort studies in the literature. And in this pooled data set, she noted that maternal subclinical hypothyroidism seemed to be associated with increased risk for pregnancy loss, for placental abruption, for preterm rupture of membranes, and also for neonatal death. There are more studies that have been published since that time, and I think one of the exciting developments in this field is the establishment of a new thyroid and pregnancy consortium. I am one member of what's quite a large group, and we have now been able to compile data from 19 cohorts, which together comprise 47,000 pregnant women, and have looked using individual participant level meta-analysis. And in this very large data set, looking specifically at the outcome of preterm delivery, we saw that subclinical hypothyroidism is associated with preterm delivery, and actually also so is isolated maternal hypothyroxanemia. In fact, that might be a more powerful predictor. Another fairly novel analysis is this one that just came out this year from China, here with an enormous data set of almost 6 million Chinese pregnant women. All of these women had a serum TSH drawn within 6 months prior to conception. And what they saw was that preconception TSH actually seemed to affect the pregnancy outcomes in as sort of a U-shaped relationship, so that both low and high maternal free T4 prior to conception, or low versus high TSH prior to conception, were associated with increased risks for preterm delivery, for perinatal infant death, and for having children who were small for gestational age. And they concluded, based on this analysis, that the optimal preconception range for TSH may be around 0.4 to 2.5. Now, an important theme that emerges as you look at this pregnancy data is that there seems to be something either additive or synergistic about having both a modest TSH elevation in pregnancy and also having thyroid antibody positivity, probably particularly TPO antibody positivity. I think that's nicely illustrated by this cohort from China. 3,300 pregnant women in early gestation, they stratified based both on the serum TSH level and on the presence or absence of thyroid antibodies. And they looked primarily at miscarriages and outcome here, and you can see in the top line, women with serum TSH in the 2.5 to 5 range, so essentially mostly what we now consider high normal, who are antibody negative, did not have an increased risk for miscarriage. But when the TSH was frankly elevated in the range of 5 to 10, those TPO antibody negative women did have increased miscarriage risk. The women who were TPO antibody positive but fully euthyroid also had increased risk for miscarriage, but the highest risk is when both risk factors are present. So the women with a high normal TSH, 2.5 to 5, who also had antibody positivity, had an odds ratio for miscarriage compared to really euthyroid TPO negative women of about 5, and that odds ratio almost doubled to almost 10 when the TSH was frankly elevated in the range of 5 to 10, and those antibodies were also present. Now, the other important factor to consider in thinking about whether or not we should be treating our mildly hypothyroid pregnant women is the effects not just on the pregnancy itself, but also on child brain development. And we certainly know from the iodine deficiency literature, we know from animal models, that thyroid hormone, particularly probably in the first trimester of pregnancy, is critically important for normal fetal brain development. These are older data now. This is kind of a landmark cohort study from Jim Haddo and colleagues published in the New England Journal back in 1999. And here they looked at children of mothers who'd had untreated hypothyroidism in pregnancy, a mix of overt and subclinical hypothyroidism here. They assessed child IQ at 6 years of age and found that those children whose mothers had had the untreated hypothyroidism during gestation, on average, had IQ that was 7 points lower than their peers whose mothers had had euthyroidism during gestation. And the children of the hypothyroid mothers also at higher risk for having IQ less than 85. Subsequent analyses have looked further at this association between maternal thyroid function and child IQ. Most recently, we have this analysis from 3 European cohorts that stratified, that looked first at child IQ in relation to maternal TSH and really didn't see an effect. So maternal TSH may not be the ideal predictor, but maternal free T4 was predictive. And they looked at the effects of maternal free T4 in gestation on both child verbal IQ in the upper left and on child nonverbal IQ in the upper right. And what you can see is those relationships are different. So there's a positive, very linear relationship between maternal free T4 levels and child verbal IQ. So the higher the mother's thyroid hormone, the better the child's verbal IQ scores will be. But the relationship is more complex for nonverbal IQ. You can see here that it's an inverse U-shaped relationship, so that low maternal free T4 and high maternal free T4 seem to be associated with lower child nonverbal IQ scores. So if we think that even mild forms of maternal thyroid hypofunction may be associated with deleterious effects on obstetric outcomes and on child development, if we treat those mild forms of maternal thyroid hypofunction, can we improve outcomes? And here, the data get kind of murky. So there aren't very many randomized clinical trials in the literature to date. I'm going to share a few of them right now. The first is this trial, now more than 10 years old. This was done by Roberto Negro in Italy, and they randomized women in early gestation, 9 weeks, to one of two strategies. Either a universal screening strategy in which all women had thyroid function tested and were treated with levothyroxine if the TSH was greater than 2.5 and TPO antibody was present. The comparison group here were women who got a case finding approach where thyroid function was only assessed if they were considered to be at high risk for having hypothyroidism in the first place. And in those women who did get tested, they were treated based on the same parameters. The primary outcome here was a composite endpoint of essentially every gestational outcome that's ever been associated with maternal thyroid function. This included some fairly soft endpoints like need for C-section, so maybe not the best study design. What they found here was, first of all, no effect of the universal screening versus case finding approach on this composite outcome. It was a negative trial. I think these data, though, are more useful if we think of this not as a trial between universal screening and case finding, but as a trial of low-dose levothyroxine therapy in women at low risk for having hypothyroidism in the first place, that's these women in the green bars, if they are TPO antibody positive with the TSH greater than 2.5. And if you think about it as a trial looking at specifically the effect of intervention in this group at low risk for having hypothyroidism, you can see that there actually was an improvement in the composite outcome that was statistically significant. So probably not the ideal trial design, however, to look at the question of real interest. More recently, we have a pair of trials from Faridun Azizi's group in Iran. This is the first of those in which they randomized women at 10 to 12 weeks gestation to levothyroxine therapy versus no treatment. These were all women who were TPO antibody negative and whose baseline TSH was in the range of 2.5 to 10. They had 183 women in the treated group compared to the controls. And the primary outcome here was preterm delivery, and they saw no difference in the preterm deliveries in the treated versus untreated women. However, in sensitivity analyses, when they restricted the analysis just to those women that we now currently consider to be hypothyroid, where the baseline TSH was greater than 4, they did see a reduction in preterm deliveries with treatment. So again, probably not the ideal study design, but a suggestion, perhaps a benefit for those women. The companion trial to that one, also done by the Azizi group, was this one in women who were TPO antibody positive with a TSH up to 10. So a mix of women who were subclinically hypothyroid and women who were euthyroid. They were randomized at 11 weeks gestation, again, to low-dose levothyroxine versus no treatment. The primary outcome, again, preterm delivery. And in this trial, they did see a significant reduction in preterm delivery risk in the treated women compared to the untreated women, also a decreased likelihood that children would need neonatal admission. An important caveat here, though, is that in sensitivity analyses, again, these benefits really only accrued in women with a TSH greater than 4. Now, we have two much larger clinical trials, both published in the New England Journal, that have looked at the effects of treatment of mildly hypothyroid or hypothyroxinemic women, specifically on child brain development. This is the first of those trials led by John Lazarus and conducted in the UK and in Italy. And here they screened 22,000 singleton pregnancies in order to randomize women to one of two strategies. In the screening group, women had thyroid function checked in early pregnancy and were treated with 150 micrograms of levothyroxine daily if they either had a TSH in the top 2.5 percentile or a free T4 in the bottom 2.5 percentile. The controls were women where thyroid function was assessed at the same time in pregnancy. In fact, they had blood drawn at the same time in pregnancy, but it wasn't actually measured until after delivery, so there'd be no ethical problem with failure to treat. So those women were not treated. They wound up with about 400 women in each group, and they followed children out to 3 years of age when they performed IQ testing as the primary outcome. And they saw no difference in child IQ at that 3-year time point, so overall an unequivocally negative trial. However, I think there are a couple of important caveats here. The first is that randomization was at a mean of 13 weeks gestation. So if we think the first trimester is the most critical time window to see the effects of maternal thyroid function on child brain development, it is possible that this intervention was simply too late. The other caveat relates to the dose of levothyroxine that was employed. So they used a high dose of levothyroxine, 150 micrograms a day. And at the time this trial was developed, the rationale was they didn't want to risk failing to see a benefit by virtue of undertreatment. But what we know today that was not known at that time is the relationship I showed you a few minutes ago, that there's an inverse U-shaped relationship between maternal free T4 and child nonverbal IQ. So in light of that knowledge, it is possible that what they did in this trial was to take women with free T4 that was really too low and to change them into women with free T4 that was really too high. And perhaps they missed sort of the ideal range in the middle. We don't know. Subsequent to that trial, we have an even larger one. This was funded by the NIH, conducted at multiple centers across the US and led by Brian Casey. So in this trial, it was an enormous effort. They screened 100,000 pregnant women in early gestation in order to place them into one of two parallel randomized clinical trials. In the first trial, women with hypothyroxanemia were randomized to levothyroxine versus no treatment. The levothyroxine here at much more reasonable doses. In the companion trial here, the parallel trial, women with subclinical hypothyroidism, which was defined as we currently define it as a TSH greater than 4 with normal free T4, again randomized to lower dose levothyroxine versus placebo. They followed the children of these women out to 5 years of age, and this was really meticulously conducted. There was almost no loss to follow-up. And they found at age 5, no significant difference in the IQ of the children who had mothers who were treated compared to the women of the mothers who got placebo. So we have another resoundingly negative trial with, I think, another couple of important caveats. So the first one, again, relates to timing of the intervention. Women in this trial were a mean 17 gestational weeks at randomization. So again, if the first trimester is a critical window, that may have been missed. The second is a suggestion that perhaps this trial was underpowered. They had powered the study to see a 5-point difference in IQ between groups. What they in fact saw was a 3-point IQ increase in the children of the treated versus untreated women. This was not statistically significant. However, if you go back and look at a number of the cohort studies that suggest that women with hypothyroxanemia have children with lower IQ, that IQ difference in mild hypothyroidism, hypothyroxanemia is often on the range of around 3 points. So possibly this was underpowered, but they had to screen 100,000 women to get to this trial, and there's no way anybody's ever going to fund a trial large enough to truly see a 3-point IQ difference. So whether this is real or not, we simply do not know. Now, they looked at essentially every obstetric outcome that's ever been reported in association with maternal thyroid function in this pair of trials and saw no effect. So I think it's pretty fair to say that intervention at 17 weeks gestation is unhelpful for obstetric outcomes here. In writing evidence-based guidelines, it is challenging when the evidence base is not optimal. In the current iteration of the ATA pregnancy guidelines, we opted for a stepwise approach to this. So that in women with a TSH elevation in gestation, it may make sense to get a TPO antibody measurement as a next step because that can help influence treatment decisions. We said first that women who are overtly hypothyroid should always be treated in pregnancy. There's no disagreement there. Again, that's not based on trial data, but it's based on sort of biological plausibility. We also recommended that any woman with a TSH greater than 10 should have levothyroxine initiated in pregnancy. And again, that's not really because of pregnancy trials, but we'd be treating those women outside the pregnancy setting, and there's really no reason not to treat them during gestation. The women who are normal, the TSH is less than 4 and the antibodies are negative, should not be treated. Women who seem to be at the highest risk, at least based on the observational cohorts, for adverse obstetric outcomes are those women where the TSH is greater than 4 and there are also TPO antibodies present. And there's a little bit of trial data, I showed you, not perfect data, suggesting a benefit for obstetric outcomes in those women. So we did recommend treating those patients, again, TSH greater than 4, TPO antibody positive. For the in-between women, the women where the TSH is high normal, 2.5 to 4, but the antibodies are positive, or the women where the TSH is elevated in the 4 to 10 range, but the antibodies are negative, we don't know. We don't have trials that really show evidence of benefit really for those women. On the other hand, risks of low-dose levothyroxine are fairly minimal, and we recommended consideration of treatment for those groups. I think most endocrinologists, myself included, do typically treat when the TSH is greater than 4 in pregnancy. And then finally, we recommended against treating women with isolated maternal hypothyroxanemia. First of all, because right now there are no clinical trials showing benefit for those women, but also because free T4 assays do not function very well in pregnancy, and it would therefore be very challenging to understand what the appropriate thresholds would be for initiating treatment and for targeting therapy. It's important to note, though, that the ATA guidelines are not the only guidelines for this out there. There are many other guidelines. And in the US, the American College of Obstetricians and Gynecologists has fairly recently updated its own thyroid and pregnancy guideline and has different recommendations from the ATA. So ACOG is in agreement that we should always treat women who are overtly hypothyroid, but they recommend specifically against treating women who are subclinically hypothyroid, regardless of the degree of TSH elevation or regardless of TPO antibody status. So important to note that our obstetric colleagues may be following different rules. In women, so that's sort of the disagreement about who should be treated for hypothyroidism. How to treat is I think, better understood, and there's more consensus. So certainly women with hypothyroidism that's known prior to pregnancy, even if they're perfectly controlled on thyroid hormone replacement before conception, most of those women are going to need a levothyroxine dose increase in pregnancy to remain euthyroid. That's largely due to increases in thyroxine binding globulin concentrations, but also due to the presence of a high level of type 3 deiodinase, which is inactivating in the placenta, which effectively more rapidly metabolizes thyroid hormone. And so it's recommended that any woman of childbearing age who's on thyroid hormone replacement should really be counseled in the preconception setting. She should know that as soon as she becomes pregnant, she needs to increase her levothyroxine dose by 25 to 30%. One way to do that is by just adding 2 extra pills a week if women usually take a pill once a day. And TSH needs to be checked every 4 weeks up till about week 16 of gestation when requirements tend to stabilize. So women should know both to increase their dose and to contact their care providers immediately once they become pregnant. If we're going to opt to treat women with hypothyroidism in pregnancy, the goal of therapy is recommended to be a TSH in the normal range but below 2.5. I told you earlier we now consider an upper limit of TSH to be 4 in early gestation. But the idea here is that, again, we don't want to risk undertreating pregnant women. We think it's safer if you have to err on the one side or the other to overtreat than to undertreat. And so we don't want to risk treatment that's ineffective. So the ATA recommends targeting that TSH less than 2.5, and actually ACOG here is an agreement. So our obstetric colleagues may not treat the same patients that we do, but they're going to treat them to the same targets. Importantly, the only medication we really should be using in pregnancy for thyroid hormone replacement is levothyroxine. So other forms of treatment, either combination therapy with T3 and T4 or desiccated thyroid, really should not be used in gestation. And again, there is widespread agreement on this. Then that's because the T3 may or may not cross the placenta to the fetus, but it unequivocally from animal models does not get into the fetal brain. So the concern is that in a pregnant woman who would be treated with any kind of T3 containing therapy, we might be optimizing her TSH on that therapy and keeping her euthyroid, but the fetus then could be selectively hypothyroid with adverse downstream effects potentially on fetal brain development. So women who are planning pregnancy in the preconception setting, if they're on T3 containing therapy, better to change them to levothyroxine alone before they try to conceive. And then management in the postpartum setting. So certainly in patients where we've increased thyroid hormone for conception, we can decrease their levothyroxine doses as soon as they deliver. Really those changes, most of the changes that drive the requirements for increased T4, the deiodinase in the placenta, the high TBG levels, those resolve quite quickly after delivery. So we can go straight back to the pre-pregnancy dose after delivery in women who were treated before pregnancy. And important then to test a TSH at about 6 weeks postpartum, just to make sure that that dose is still the appropriate dose. Now, in the women in whom we've initiated levothyroxine during pregnancy for, subclinical hypothyroidism, for sort of a more marginal indication, particularly if they're only requiring low-dose levothyroxine, they may not need lifelong thyroid hormone therapy. You know, if they have mild thyroid compromise, essentially can't keep up with the demands in gestation, they may still be able to have enough thyroid function to maintain normal thyroid hormone synthesis outside the pregnancy setting. So the recommendation is in those women, we can certainly consider, you know, tapering or stopping levothyroxine as a trial to see if they still need it after pregnancy. I typically do not do this at delivery. I typically wait until the baby is sleeping, basically because I think it is not nice to women who may be exhausted from a newborn who's up all night to also risk making them hypothyroid at the same time. So I typically wait till the baby's sleeping and then try stopping the levothyroxine. And again, important to know that you need to check a follow-up TSH in 6 or 8 weeks to make sure that women do remain euthyroid off of it. So I would conclude by noting that we know that there are a number of adverse effects of hypothyroidism on pregnancy outcomes themselves and on child neurodevelopment. And unequivocally, overt hypothyroidism always requires treatment in pregnancy. We can consider treatment of women who are subclinically hypothyroid, and consideration should probably depend both on TSH level and on TPO antibody status. Treatment right now is not recommended for isolated maternal hypothyroxanemia, although that certainly might change down the road as additional trials are done. And when we are treating with thyroid hormone in pregnancy, our treatment target is to a TSH less than 2.5. That's probably also true in the preconception setting. And during gestation, especially in the first half of gestation, we should be monitoring TSH fairly frequently to make sure women are getting to target. So with that, I thank you for your attention.
Thank you very much, Elizabeth, for a nice review of the topic, as usual. Excellent. We'll ask all our panelists, please, to open the mic and the camera, and please join us for the Q&A session. And for our audience, we'll ask them to kindly write down their questions in the Q&A section. So we have 3 out of 4 of the panelists. And I think Christine might be joining a little bit later. So I think we'll start the Q&A session. Since Christine is not here, I'll start with Elizabeth. And there is a, I don't know, this is interesting question, says, a pregnant lady received amiodarone during the CPR. Is the baby going to have abnormal thyroid function test, or what's happening to the thyroid function test of the baby?
So CPR, help me with that. What's that abbreviation?
That's the resuscitation. So that's a code situation.
Oh, so it was coded. All right. Well, that probably presents a lot of problems for her pregnancy. She's got significant cardiovascular disease. But with respect to the amiodarone in pregnancy, the fetus does not develop the ability to fully escape the acute Wolff-Chaikoff effect until very late in gestation, about week 36. So when a pregnant woman gets a high dose of iodine, including a high dose of iodine, presumably from amiodarone in gestation, it's possible that even though she may be able to maintain euthyroidism, the fetus selectively might become hypothyroid in the second half of pregnancy when that fetal thyroid is working. So I think unequivocally a woman who needs amiodarone for her cardiovascular health, that's probably a priority. I don't think it's wrong to use it in a setting where that's needed. But need to be aware of the concern that there might be the potential for fetal hypothyroidism, and certainly would monitor that newborn, right after delivery for thyroid function.
Agreed. Saving the mother is a priority. So a question to Alex and says, if you are using combination therapy, what time you would check the thyroid function test? T3, and what time you will advise for taking the T3 as well?
Thanks. Yeah, I mean, to be honest, I mean, I'm really following TSH predominantly because the T3 levels I find to be less helpful in that setting. Even though I check them, I really look at TSH. I typically would check it 3 to 6 months, usually 3 months after I start a combination trial.
Excellent. There is a question about the effect of fasting on thyroid function test. Salman, I think you answered this, but I think it's good to repeat as well for the general audience that joined us later.
Yes, indeed. So both fasting and food have an impact on thyroid function, both in people who have their own thyroid functioning normally, as well as people on levothyroxine for various reasons. Part of it is related to the effect of the food itself and the other hormonal implications of eating and fasting. Prolonged fasting had its own impact, as we see in people in illness and so on. People on levothyroxine, the issues again probably pertains more to absorption and the impact of food with the absorption of levothyroxine, and therefore the recommendation to leave at least half an hour and ideally more between food itself and the levothyroxine. So yes, but what is important to stress is that the effect is probably not as clinically relevant in the vast majority of people. So you wouldn't expect to see a difference of 6 or 7 international units, milli international units of per liter of TSH or so. It should be in the 0.2, 0.3 range, the effect of food and so on.
Thank you. There is a question about resistant hypothyroidism. So if somebody would like to tackle this. We'll hear from all of you. We'll start with you, Salma.
Okay, so I'm assuming that when somebody talks about resistant hypothyroidism, they probably mean high TSH while somebody is meant to be on adequate doses of levothyroxine rather than resistance to thyroid hormone, which is a completely different condition.
Yep, correct.
Okay, so yes, and I think there are probably many reasons, and this is one of the most frequently encountered scenarios in clinical practice when the patient comes in and claims that they have been taking the levothyroxine as prescribed every day and has been doing that for forever. And for a lot of people who do take regular medications, including medications for diabetes and hypertension and any long-term condition, we do know that there are times when people can miss their medications for perfectly valid reasons. So I think the first thing that they have never missed a dose is probably false. Now, the vast majority of people do probably take the levothyroxine every day. They might take it at different times. They might not stick to the recommendations of leaving a gap with food. So there can be a number of reasons why the TSH might be different. Having said that, there are probably other reasons apart from compliance that we also should keep in mind. Things like malabsorption. People with one autoimmune condition may develop other autoimmune conditions, such as celiac disease, such as pernicious anemia, and so on. So that needs to be assessed. Other medications, that's another common. I know Christine has talked about medications causing hypothyroidism, but medications itself can interfere with the absorption of levothyroxine. We've seen issues with proton pump inhibitors, which are very commonly prescribed. And finally, I think when we do have this discussion about resistance to the action of thyroid hormones, we frequently encounter this, but when we actually bring in patients for observed high-dose levothyroxine supervision, I am yet to see somebody who hasn't suppressed the TSH.
Thank you, Salman, and we welcome Christine to our panelist. This is a question regarding difficulty keeping TSH or the need for high-dose thyroxine to normalize TSH. One of the audience that mentioned this was referring to resistant hypothyroidism, where we think it's just the need for higher dosing of thyroxine to achieve normal thyroid function test. I will ask Alex, what pathological condition a practitioner should think of when you need to give higher dose to normalize TSH, while we are sure that we excluded non-compliance issues?
Yeah, thanks. I mean, I agree with what Salman said. I mean, I think a lot of times it comes down to compliance, but there are times, where, people have different issues with absorption. And, I think, often about celiac disease, potentially patients who increasingly around here who are getting, gastric sort of surgeries for obesity. Sometimes that affects the absorption as well. A lot of times proton pump inhibitors are considered to be not interfering, but they are. I usually will go through, a very detailed question with the patient of how they're taking it, because usually there's something there. Now, if that's not the case, and they say they're taking everything appropriately, I might look at, in those situations, I might look at as Salman was saying earlier, what formulation they're taking, how they're storing the medication, and in some cases, I'll try, thyroid hormone via gelatin capsules, which potentially don't have any excipients, to see if that makes a difference. But a lot of times it comes down to that. We will do the absorption test, like Salman was alluding to, where we give a high dose and we monitor it in the office. And I agree, usually, almost always, it's an issue of how they're taking the medication. In our hospital, a lot of times patients will be given medications. They'll be given their thyroid hormone in the morning. It'll be written as give every morning. And sometimes that medication in the hospital will be administered with all their other medications, which can sometimes interfere with the absorption as well. So we look really closely at how the patients are taking the medication first and foremost.
Excellent. So we'll go to Elizabeth. How frequent do you do this thyroxine absorption test or thyroxine challenge test?
Maybe a handful of times over my career, not often. And I, like the others, have never actually seen anybody who wasn't absorbing. I might throw out a couple other things that I think about in this scenario. One is nephrotic syndrome, usually sort of other clinically apparent for other reasons, but people can lose thyroid hormone with protein in the urine. So that's just one to sort of think about when people need sort of astronomically high levothyroxine doses. And I often start, actually, maybe I'm cynical and I don't think my patients are telling the truth, but when they tell me they're taking their thyroid hormone all the time, I call the pharmacy and say, are they actually picking up their prescription? And often the answer is no.
We'll hear from Christine about thyroid challenge test. Are you doing it?
I do a fair few thyroid challenge tests, actually. We have a large population of patients with abnormal thyroid function tests despite allegedly taking high doses. I am yet to come across someone who's not absorbing. I'm actually doing it in someone who's pregnant at the moment. TSH was 250, and within a week it's come down to 150. But it is very difficult to deal with. I've seen, as Elizabeth says, nephrotic syndrome in pregnancy, actually causing significant problems there. But yeah, we do it. I see there's some questions about maximum dose of thyroxine. There is no such thing as a maximum dose. So I get a lot of questions from GPs here in England who say, oh, in the BNF, it says the maximum dose is 200. There is no such thing. It's whichever dose the patient needs. But anyone who needs more than 200 micrograms, something is not quite right, generally.
Okay, thank you. There is a question about, again, perhaps Elizabeth, risk of adverse pregnancy outcomes. How do you communicate to the patient? So imagine a young patient who had a total thyroidectomy for a low-risk PTC coming for the first time. She's pregnant and her TSH 5 to 7 over 2 months period. She's scared that the OB-GYN or the family physician told her that she's going to develop adverse outcomes. How common are the adverse outcomes of subclinical hypothyroidism?
Again, based on the observational data, they're higher than in people who are fully euthyroid, but they're actually not that frequent. And in fact, bear in mind that our obstetric colleagues wouldn't treat a TSH of 5 to 7 at all based on current ACOG guidelines. So there's unequivocally no consensus that that's a level that should, I mean, it's not the level I'm aiming for, certainly. And when I see those numbers in my practice, I do treat it. But we don't have unequivocal evidence that a level like that is going to adversely affect, a particular pregnancy. And I think often reassurance, I'd probably increase the dose, but it also would sort of reassure the mother that the likelihood of adverse consequences is relatively low.
Thank you. Alex, the question about dietary intake and the iodine metabolism. Any diets to avoid or any diets to be encouraged for patients with hypothyroidism?
Well, so patients will read all the time on the internet, there are certain diets they should avoid. I think, and I'd be interested to hear what Salman has to say about this as well. But, there's really, to my knowledge, no benefit in terms of the dietary maneuvers that patients say, the so-called anti-inflammatory diets, in terms of improving thyroid function. I don't know if I've ever seen a patient necessarily who's developed a goiter from soy products or cruciferous vegetables like broccoli or kale or cauliflower. Nevertheless, patients will come in asking about that. I think that for majority of people that are eating normal routine healthy diet, which sometimes includes those things, including soy or cruciferous vegetables, I don't really necessarily tell them not to do that. I think that a couple times a week is a reasonable thing to do. What I do see sometimes is people that are taking quote unquote iodine supplements to improve their thyroid function. And as we've seen, with the Wolff-Chaikoff effect, some patients, particularly those with autoimmune thyroid disease, actually inhibits their thyroid function rather than improving it. So I do generally tend, and also thyroid, quote unquote, thyroid supplement, or health or thyroid support vitamins the patients sometimes will get are actually sometimes adulterated with thyroid hormones, and those can actually really lead to significant thyroid problems, particularly over excessive ingestion of thyroid hormones. So I tend to tell people to eat a normal healthy diet without excessive amounts of those things, but I don't really tout any specific diet per se, if that helps.
Thank you. Move to Christine. There is a question about a situation in which a patient needs to go for emergency surgery or emergent surgery, and at the same time found to have severe hypothyroidism. What would be your recommendations in that situation?
Yeah, I think it's an individualized decision making together with the anesthetist, and it depends on the sort of general status of the patient. It depends on the urgency of the surgery and the indication. So, if this is a very frail elderly person, where I think hypothyroidism will have significant consequences for the heart and therefore anesthetic risks, I'd probably err on the caution and postpone. It depends on the degree of hypothyroidism. I have in a number of patients given high dose levothyroxine where I thought, they're young, their heart will tolerate it, they need surgery for cancer. That's really gonna significantly impact their life, and sort of try and get them, get their thyroid status a little bit better within a week. At least make their heart a little bit less hypothyroid. But I think it's a multidisciplinary decision. Depends on how brave your anesthetist is, how brave you are, what the patient, how severe the hypothyroidism is, what the indication of surgery is, and then you make an individualized decision. But so on occasions I have given high dose levothyroxine to try and sort of stabilize them a little bit so that they can have the urgent surgery they need. If it's non-urgent, then I would just say postpone until thyroid status is normal.
Excellent. Salman, there is a question about, I think this is an important question for the audience and the general practitioner. If you treat somebody just started treatment, antithyroid drugs for Graves' disease, or you refer the patient for radioiodine treatment to manage thyrotoxicosis, which of the labs you will utilize most, TSH or free T4 in the immediate post-treatment period?
I would do both. But I think if by some rule or law I'm limited to one, you'd probably expect to see immediately. I mean, generally it depends on when you're going to check the thyroid function, but in most cases, if it's 4 to 6 weeks after the procedure, I'd probably go with T4 because I still expect to see the TSH to be low at that stage in these patients.
Thank you. Elizabeth, there's a question about the 25% increase in thyroxine dose during pregnancy. Do you see a subpopulation of pregnant women that may need higher than that 25%?
Yes, absolutely. And it's going to be very variable depending on what the underlying reason for hypothyroidism is. So women who are athyroidic after thyroidectomy or radioactive iodine ablation may need a substantially higher dose increase than that potentially. Women who still have some underlying thyroid function may need less. And it's not every patient that needs that increase. In studies, I think the requirement for dose increases ranges from about 50% to 84%. So it's going to be usually the majority of women who do need more, but how much more may depend a little bit on why they're hypothyroid in the first place. And you might want to go a little higher than that initial empiric increase in somebody where maybe the baseline TSH is a little higher and they don't have any residual thyroid function.
Thank you. Alex, question about patients with hypothyroidism newly coming to your practice. When would you challenge the diagnosis of hypothyroidism and the need for thyroxine?
Oh, yeah, thank you. Yeah, I mean, sometimes, TFTs initially when they're checked are abnormal, but when you repeat them 3 or 6 months later, they're normal again. So I typically will wait at least 3 months and repeat the TSH and see if it's persistently an issue. There was a large study done, I believe it was at UPenn, University of Pennsylvania, which showed that 50% of those patients, when you repeat the TFTs, are normal again. So I do think that when you pull the trigger on, you have to think about it when you commit somebody to taking levothyroxine, they may be taking that for life. And so most often they are. And so I really think of it very carefully, and I don't necessarily prescribe it on the first time that I see the patient, but I will repeat them again about usually 3 months later to see if that's persistent or not.
Excellent. I think there are a number of questions about the maximum doses of thyroxine used in practice. Do you mind answering this question? We'll start with Elizabeth, then Alex, Salman, and Christine. The highest dose of thyroxine you used.
I think my colleagues have already said that there's no upper bound. I've used, 600 or 700 on rare occasions in people who really don't absorb well. So I think you use as much as it takes as long as you're convinced people are really taking it.
Okay, we'll move to Alex, maximum dose of thyroxine.
I agree. There's not a maximum dose, though. Again, when we're getting significantly above 1.6 mics per kilo, again, I'm questioning compliance, number one, and then absorption, number two. And so sometimes I'll do the studies we talked about earlier.
Okay, I think just to complete the same question, Salman and Christine, I heard your view, but I think just for the satisfaction of our audience. Salman, I think you are.
Sorry. The highest I've ever seen being used is a patient who was using 800 micrograms a day, severely obese with congenital hypothyroidism. And we only found out when he actually came in for his thyroxine absorption test that he had quite a marked tremor. So when he was putting all 8 tablets of his 100 micrograms into his hand and putting them into his mouth, about 2 were going in and the 6 were on the floor. And it's likely that his floor in his house is probably covered in levothyroxine tiles, I imagine.
Christine?
Same here. I've probably had patients on 600-700 micrograms a day, allegedly, whether it's accidentally or deliberate that they're not actually quite taking that dose. There is no maximum. It's whatever dose is needed to try and get the patient euthyroid.
Thank you. There's a question about the change of thyroid function test with changing the brand of thyroxine? Perhaps Alex will turn over this question to you.
Yeah, thank you. So when you know, as we sometimes see, you know, I tell patients, you know, if you buy like a 200 milligram ibuprofen pill, it's not necessarily always 200 milligrams. If you buy like the store brand versus, you know, the Advil brand or whatever it is, you know, tablets don't always have exactly what's listed on the label. And generics and brand of levothyroxine are no different in that respect. And so when somebody switches between generic manufacturers or between brands and generics, there's going to be some inherent fluctuation. I personally feel that in most patients, when you treat them, that 5 or 10% difference is usually not clinically relevant. But there are some, particularly if we're targeting a very low TSH, like thyroid cancer, where we're trying to, you know, target between 0.1 and 0.5, for instance. You know, that difference between generic and brand name may make a difference. And so sometimes I will prefer the brand name in those situations, so that I know that they're always getting, if it's a 100 microgram tablet and it's 97 micrograms they're getting, at least it's always 97. You know, so you do see some fluctuations when somebody switches brands. I would say that when you're switching between desiccated thyroid hormone products like pork thyroid products like Armour or NP thyroid or whatever it is, and you're switching them to levothyroxine synthetic, you just have to check the you know, you can say, well, 60 milligrams of pork thyroid product is roughly equivalent to 100 micrograms of levothyroxine, and that may be true. But the point is, you have to check their TFTs again 6 or 8 weeks later to make sure that the dose change is appropriate.
Excellent. Salman, there is a question about Ramadan and fasting. What's the best time to take thyroxine without dietary dietary effect? The best time.
Okay, so I think it depends on the time of the year. So for example, if the difference between when you break the fast and open the fast is large, you can probably still keep in half an hour to an hour's gap between food and taking the tablet. But if it's relatively small, I would suggest then keep taking the tablets. It's only for a month, and then you can go back to the usual, you know, mechanism after the month. So it shouldn't have a huge impact, but it kind of depends on the time gap you have to be able to take the tablet.
Thank you, Salman. I think it's about time. For me, I think we answered all of the relevant questions that I've seen. Okay, so there is a question here. Perhaps we can end with this. But 3 months post radioiodine for Graves' disease, TSH is 0.3 and free T4 is 3.8. I don't know which unit is they're referring to. Would you start thyroxine? Patient has no signs of hypothyroidism. I guess the free T4 perhaps is in the normal range. That's why they're asking. Any comments? Elizabeth, what's the unit you use for free T4? What's the normal range you have in your lab?
No, so our reference range would make that quite high. So I think that's not using a US reference range.
So we'll leave that question. Then I think it's about time.
If it's picomoles per liter, then that's low. And I presume that's what the question is aiming at, that TSH is still low, but free T4 is also low. So it depends on whether anti-thyroid drugs have been restarted after radioactive iodine. Because obviously if that's the case, then you stop it. It also depends on whether this patient is symptomatic. If this patient looks hypothyroid, then they're probably becoming hypothyroid. You would expect, you know, that their pituitary response with a TSH rise, but you can get funny thyroid function test after radioiodine. So definitely close observation. If the patient looks And if it's a picomoles/liter, then that patient is profoundly hypothyroid based on that 3T4. The patient should have symptoms, and you would be able to see that. Otherwise, I would suggest hold tight and repeat after 4 weeks and see what happens.
Thank you very much. I think we come to the conclusion for the Q&A section. And I'd like to thank our panelists for their excellent presentations and interaction and answering the questions of the audience. There are, however, some announcements for our audience about our upcoming activities. And I will ask kindly our EDS team to show us the slides of the upcoming activities. So a couple of announcements. First of all, for the CME activities, CME credits will be available in 14 days. Please fill out the evaluation form that will be sent to you on your email, and then hopefully you can get the CME hours. For the next announcement. So for our Young Leaders Forum, we have the Endocrine Disorders in Women coming in December 15, 2021. And this will be the last title or topic for this year. In 2022, we'll be coming with different titles. For our thyroid webinar series, we have 3 more to come. So in March, we have 2 sessions or 2 webinars and 1 in April. So we'll be covering thyroid and surgery and thyroid nodules in more details. We'd like to thank Merck for sponsoring all of these webinars. And also we'd like to remind you with our EDIC 2022 Congress, it will be a virtual conference in February 24th to 26th. You are encouraged to look for the updates on this conference. We'll have multiple international speakers with interesting topics as usual. I'd like to thank our panelists again and thank our audience. I'd like to thank MCI for arranging this webinar today. And see you in our next webinar, part 4. Thank you very much.